And we'll start off with the pledge to the flag in that corner. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I would guess that we don't have any public. It looks to me like this is mostly architects. Is that right? Okay. So we won't worry about public comment at this point. Consent agenda items. Does anybody have any issues there? If not, I'll ask for a motion.
So moved to be approved as presented.
I'll second that.
Those in favor?
Aye.
Thank you. Clinic remodel, ZCS Engineering.
We have our team here, and you'll indulge us. As you know, we had signed an agreement with ZCS this past spring, early summer, and we're pretty darn close. We have reviewed this with our doctors multiple times. Most recent, after you recall, well, not all of you were at the joint conference meeting where the doctors voiced some concerns about the size of a couple of the rooms and locations. So the ZCS team has revised that, and I must say I saw the preliminary drawings this morning and last night. I don't think I sent them out to you, did I? I did. No, I did send out.
You got something on.
They're on the website.
They're on the website, and I think we sent them maybe Monday.
I have
So-
them right here too, Charlie.
Good.
So if you wouldn't mind just taking one and passing it down, and then just kind of a little synopsis of the agenda too. Or maybe. Yeah, the whole staple package, I guess.
Yeah.
Glad to hear it.
Mostly I've seen, I'm not seeing them, so.
Is everything okay with Sorry, I don't.
I don't know. Leslie.
And then I brought you some both too. My name is Kelsey Womble. Kelsey. Yeah.
Oh, there's some more things.
The two down there, it's one of the ones.
Send me a note saying so.
How's Shane?
It's actually right inside of it.
Thank you, nice to see you. Glad you're part
Leslie, I'm not sure who wants to.
Well, it's, everybody want to get started? Yes. Okay. Thanks for having us back. My name's Russ Carter. This is Kelsey Womble. Marcy's standing back there, and Yabori sitting down. This is our project team. We're coming to the end of our schematic design phase. Kelsey's going to walk you through everything. There's a little agenda attached, sort of rehashes why we started this and how we got here. There's some bulleted items there that sort of highlight the main goals of the project. what we want to do with, we want to centralize reception, we need space for some additional providers coming on, and then some juggling of existing spaces. We've been working pretty hard with the district and some of the providers and the facilities folks, trying to convert our 3 little clinics that are out there now with the addition of some new clinic, a lot of remodeling of existing space and interfacing with new space. It's been quite a puzzle, but we're pretty happy with where we've ended up. Charlie seemed to be pretty satisfied. I'm patting myself on the back just for getting there, because that wasn't easy to do. But I'd like Kelsey to, I know we don't have a lot of time, but if you'd like, she can sort of give us a little quick tour of, what you have now and what we're proposing you do. And then we can kind of talk about what it might cost and how long it might take. So there's no questions right off the bat. You want to give
Yeah,
a whirl?
we'll get to it.
Okay.
So like I said, my name is Kelsey. I've been the project manager for this. Basically, we were posed with the question to give you guys more space. So we ran through a few iterations with Charlie and some of the providers of, just a mass infill of your 3 clinics, which we're calling phase 1, phase 2, phase 3, in relation to the phases that they were built. I think that you all are familiar with that. We decided that maybe a centralized reception common space would be the most feasible to tie all 3 of the clinics together and give you sort of a commonality between the 3, and which now we're providing 4. So this is the cover sheet. On the other side, you'll see that we kind of have a breakdown what's to go inside of each facility, and then a construction schedule, and then some budget breakdowns, but like Russ said, we'll talk about that in just a little bit, and I'll go ahead and walk you through the 11 by 17 packet that I gave you guys. So if you wouldn't mind switching to the next page, I'm sorry. So this is a breakdown of, based on color for the legend, of what's going to be going on in each phase. So phase 1 is kind of the light orange, that we're calling that a soft remodel. So that's going to be selective demolition of walls, a little bit of relocating, proportioning new spaces, and then moving on. Phase 2, that's kind of your crazy hectic space. We're going to completely gut that space and give you all new per the rest of the sheets like we'll go through. Phase 3, you all seemed pretty happy with what's going on in there. So we're not going to do too much on the inside. We're going to update the outside, make it cohesive with your new remodel, and call it good. And then phase 4 is completely new construction. It's a new building altogether. And then your common reception and waiting area. And then also there was mention of maybe even future expansion, and we kind of have that illustrated over there, that you could always expand to the back if given the opportunity. So if you want to move to the next page, I believe it's phase 1, or I'm sorry, the reception. We have a little key plan on the side that can kind of show you, and so we're anticipating covered walkway, which is sort of illustrated in the some of the elevations that we've provided. Coming in, common reception. From there, I've talked to Juanita a little bit about kind of how this will play out with your computer systems and whatnot. It seems to work well. And then sending them to their waiting areas. Also, I forgot to mention on the previous page, we have a little bit of a routing diagram as far as patient and providers. So as you can see, providers and patients can maintain separate egress and ingress, and then nurses coming to get the patients in the waiting room and whatnot.
Really tried to cut down on unwanted cross traffic. That seemed to be a big issue.
Yeah, so that doctors can move freely without having to commingle with the patients. And
something interesting about this image, you'll notice that we're not tucked up tight to existing buildings, but we're linked with hallways. If there's any question as to, there may be questions as to why we did that. It had a lot to do with structural considerations and keeping new construction isolated structurally from old, isolated from new. There's a lot of triggers that go off when you attach too much new stuff to existing stuff. And plus, it would be pretty invasive, inconvenient. It would be, the nuisance of construction immediately adjacent to operational facilities. So we kind of pulled that reception common area, we kind of shrunk it a little bit, leaving some exteriors, courtyard space and things like that. So if there was any question as to why we didn't fill that hole, there's reasons behind it. So.
It also allows you to still maximize the amount of daylight in those existing structures around, rather than building right up against that, using that daylight that we all love.
We think those could be really special spaces. Charlie fought us on that, but.
So that's how we're proposing tying everything in together in our common reception. We want to go to the next page, which is page 1. And again, I don't want to take up too much of your time explaining, but please stop me if you do have any specific questions as far as space appropriation. But ample exam and office space. I know that there was some question about wound care versus just additional provider. You guys can obviously give that whichever designation you would like. You will notice in each space we provided their own checkout, so that patients aren't having to go back to the common reception, and they're instead just checking out at this space, and then they're able to leave directly, so that we don't have that cross traffic and people able to wander and getting lost amongst the halls. So I think that maybe we can go ahead and go on to phase 2. This is the one that you kind of have, and I know it's a little bit cut off at the bottom. That's pretty hectic right now. One thing that I didn't point out previously is that light dash line in the background. Those are all your demo lines, so you can kind of see where it is.
That's what's there now?
Yeah, so that's what we're planning on taking out, and then the dark black, that's what is going to be adding back in. You do have some conference space in here, additional triage space, referrals, and then this was a special request triage room, either for keeping people that you don't quite know where they fit into the clinic system, so more like a clinic walk-in, or somebody who's maybe really sick and coughing and you want to keep them away from the waiting area, kind of a place to hold them. And then a special immunization room, which I know you have now, but it's also like a quad-purpose room. So, and then exam and office space again. This checkout and billing does also serve our new phase 4, which branches off right here. So this will be the one checkout that does serve 2 phases, but we've provided enough space for that.
Does that exit go into the reception?
Actually, you would be able to, I know it's hard to see, we can point right here. You would actually be able to just come right down to this hallway and straight out. So you would still just be.
But neither of those alternate exits have a covered walkway.
No, sir, they do not. Well, I guess they are covered slightly, but they aren't covered to the little drop-off sidewalk, yeah.
Could they be?
Yes.
Yeah,
Yes.
we could provide connectivity to the drop-off spot is what you're referring to?
Yeah.
Okay, yeah.
Is there any reason during inclement weather they couldn't go back to the covered entrance that you have?
No, not at all. I mean, I don't think that you guys would be posting signs, do not enter back in or anything, no.
It seems to me that oftentimes the patient has someone in that waiting area, take them home or whatever, so they may want to come back into that general reception area. And that happens.
So when you think about it, the hallway, for example, in this drawing, the patients could exit the hallway that is currently where Dr. Graham's office is. So they're still covered. And it comes out at that exit. So that hasn't changed. It just doesn't go through the central core walkway.
It's like right here.
But at the same time, what they would be able to do, if you flip back to the page before, or 2 pages before, there you go. You see where the entrance, they would come right through there, or they would come down on the right-hand side,
Mhm.
which is still covered, and they could enter through there and pick up. So they have 2 different ways that they could, or if they wanted, they could come down through what's now specialty, because you still have, on the specialty, you still have that portal. So there are really 3 ways of
Come down
entering.
into the hospital.
Or you come down to the hospital. So none of those change, really.
We're just hoping to encourage them to go one way, but definitely not stop them from going another way. And then the next page.
No, that's it.
No, one more.
That's it.
No, there should be one more prior,
Yeah.
which is phase 3, which that's a quick one, because like I had mentioned previously, Dr. Graham's office, pretty self-sufficient, pulmonary rehab, you guys were pretty happy with this space, and then same with sleep clinic. So theoretically, for the time being, this space would not be used very much by the central reception. However, future use, if you decided to reoccupy this into clinic space, easily accommodated by the central reception. And then the next page is our final and brand new phase 4. As you can see, it's not much different, still office and exam space. However, we've also provided some special space for mental health and wellness, a multi-purpose group room, and another group room, wellness, psychology office, and then an additional office or multi-purpose room. These all are fairly large, so they could be used for a few different things or applications. And then we have some support space like soiled and clean utility, which are all required by code, and then lab and restroom for any of those options.
Charlie, is this phase going to primarily be mental health?
Big pardon?
Will this primarily be mental health? Or
No.
will the-
No.
What will be in here besides who will be, I mean, will we
Right
have
now,
some
Tara Jones.
providers? Pardon me?
Right now, Tara Jones. This does not, the additional part that, that Kelsey showed, that would be the additional components. That would be for a possibility behavioral. But this is, no, this is, this is all the rural health club.
So we have office 5, office 6, office 7, who occupies those spaces?
Office 5, 6, and 7. We have practitioners that are ready to occupy that space. And Tara right now is in space in the specialty clinic.
Are we going to have initially excess room, hoping that we add providers?
Kurt, I'm sorry to interrupt, Charlie. The bulleted points on the agenda has 8 providers, wellness and group room, mental health and group room, meeting space, the clinic, and then the pulmonary rehab. And with this space, we've actually accommodated all of these bullets with no additional space.
Okay.
You're already full. But again, extendability to this direction is that
The
to the west of
west.
phase 2, existing phase 2.
Yeah, you can keep expanding west, west, on the westward side.
And then heading towards your existing one.
Yeah, and you're actually, through those future expansions, you have a lot of opportunities to connect to your existing buildings. So again, keeping that circulation going throughout.
And we've programmed the structure structurally for pretty simple marching along for future expansions.
Charlie, the one thing that is not in here that I would like to somehow see be addressed is the hospital auxiliary at a more prominent place near the front of our facility somewhere. I don't know whether they've been asked that question or, but I'd like us to explore that, so.
Okay. We had looked at a couple of options. And what we haven't got yet to what the cost phase is. Frankly, what I thought is that to the directly west of the corridor that connects the hospital to the clinics, that space right there. There's also been some talk in front of the hospital where the MRI truck sat, 2 hospital locations. And when we started this conversation, we talked a little bit about that, but we gave ZCS the expectation to, 1, live within the $4 million budget. Number 2, figure out how to add the extra space, and then give us some bigger ideas of where we might be able to expand it. So it's a little bit above, their budget came in $20 less than the $4 million, so we're. No, maybe it's.
20,000.
Let's just check. It's pretty darn close to what we got.
Might as well be 20.
Yeah.
But I think this is the time for us to explore that.
Absolutely.
Sure. You don't go to a facility anywhere where the hospital auxiliary is located halfway to the kitchen somewhere in a hall where there's nothing.
No question about it.
Okay.
And part of that discussion that we had with Russ and with Daryl, if you recall, a year and a half ago, we talked with Daryl about how would we get heat to these new clinics. We talked about geothermal heat, and that would run through that soffits through the corridor. And if we did that, we would need to expand it anyway.
So I know this is something I'm throwing out as a new concept, but I do want to see if it's something that can be done over there. Not quite $4 million.
Absolutely.
Yeah.
And we did, early on, Charlie, discussed some, just like you said, some locations for that.
We did, I can
Along
remember
the
the
corridor.
2 locations talking, but I didn't remember how it could happen.
They were trying to live within that $4 million budget. And I don't know how much more it would cost to put in the space for, to expand that hallway, if you will.
20,000.
Pardon?
20,000.
Just round up and be done.
Well, we'll have a really good idea of where that $4 million is. The next phase of design, we go through design development, and we do the construction budget drill all over again with a better defined set of drawings, and we'll know a lot more. Maybe there's some money there. If we're good there, we'll.
Yeah, you gotta earn your keep.
So that was kind of a summary of the plans moving forward, as Russ just sort of started to talk about, is the next phase of design development. So that goes into either DD and then CD, which it would be design development plans and then construction documents. I don't know, do you want to?
You want to show them the last sheet?
Oh, yeah, I'm sorry, there is one more sheet. It's just kind of another, Corey, maybe you can explain it a little bit better.
There's some challenges, you know, your newer facility, these older facilities, different types of construction, completely different presentation, exterior. You want to talk a little bit about trying to tie it together a little bit?
When we were all discussing the overall design, collaborating on it, one thing is, you have this newer construction, so we want to bring that aesthetic over and kind of help tie the two together, and that's what we're trying to do with the central building there. And basically, the other thing, like Russ touched upon, there's a lot of structural issues with connecting directly to existing buildings. We wanted to try to avoid that. And also, like Marcy mentioned, natural light's very important in any space. And that's kind of what we're trying to focus on, in creating some light wells in that main entry that maximize natural light that's flowing into some of your primary hallways as well as that central core. And one of the big ones was also a lot of doctors wanted more natural light for their offices, so we pushed all their offices to the exterior buildings, in larger exam rooms. So we've established all those components, and really this just shows that we're simplifying how we're connecting to the existing in order to keep costs down, and that's kind of one of the primary driving forces of the entire design. And that's kind of what the massing just shows.
Now, do your estimates include like sprinkling phase 2?
Yes.
And putting siding on all the phases?
Yes.
Okay, and then what roofing do we need to do?
And then that's also includes re-roofing phases 1 and 2, the tile roofs.
Okay.
I'm not sure what that roofing is gonna be. We do know you need new roofing though.
Yeah.
We'd like to give it all a nice facelift. Again, we're gonna, the wish list is, facelifty stuff is a little bit farther down the wish list. We really wanna do that. We do know the roof is a problem though, so. The 3 existing clinics, they're very simple, light framed, almost residential and structural media. We want to stay with that for the addition, but then again, like you've already said, do something with that new central building to get it in concert with your newer hospital and create a campus.
So one of the things that would change is we have the white hardened, it's backer board on the new hospital sign. We have the green boards that are on this side. One of the things we've talked about doing for several years is to take that white and extend that to the clinics. And we talked about whether that's a maintenance team doing that or as part of this project. So as we go through the next phase, we'll figure out if we needed more money, maybe that's something that our maintenance group could do versus having the construction group do. And we're gonna figure that out.
And do your estimates, are they designed for geothermal heating and all this?
No. We had not considered tapping that line to heat this addition space. Is that correct?
Yeah, there was some consideration on like selective, like the courtyards.
We may want to, we may want to use it to melt some snow on some exterior sidewalks and things like that, but not as primary heating for the buildings. And that was an economics discussion. It's very expensive. But then again,
Even the new construction phase 4?
yeah.
If you recall last year, when we had an estimate for just replacing the units with current higher SEER unit, more efficient, the difference was $140,000 between that and geothermal heating and cooling. So we had hoped that it might be able to become less.
And it's frustrating because, well, the geothermal's there, but boy, when you add up the dollars, we were getting, I don't know, $300,000 just to get the heat there, geothermal. So, again, when we leave schematic design and get into design development, there's nothing, because that energy resource is there, we're going to make sure that that's the right decision before we move on. But from where we see now, from our seat right now, the budget wouldn't hold it.
Well, talk about your construction phasing.
The construction phasing. Let me grab one of the sheets really quick. So that's all on the front page. It's the second item down. So how we're proposing, it would be both most time effective as well as economical if you build the phase 4.
I'm sorry.
No, that's fine.
Go back to that first,
Which one?
Jen, that first second.
That one?
Let's try that one.
That's fine, yeah. If we build phase 4 and the new reception at the same time, and that construction duration, we're estimating is gonna be about 7 months, start to finish. And so once you get that built up, then you will be able to move the existing phase 2 providers. There's enough space. There may need to be some temporary walls, a little bit of temporary work done so that we can facilitate all of these providers into here. And then at that time, we'll go ahead and remodel phase 2, which we're estimating to be about 4 months. And then once phase 2 is remodeled, we'll go ahead and move, it's gonna be a juggling act, move phase 1 into phase 2. And then we'll go ahead and do the soft remodel on phase 1. And then once that's done, then everybody can go ahead and take their appropriate seats. Like I said, there may have been some temporary walls put up to partition some people. Some people may have smaller offices if we need to push and shove, but we'll make all of that right at the end and everybody will have their space.
So total time then?
At the moment, we're predicting a 14-month construction duration.
Starting when?
So that would be our next
That's all the
point.
time we have tonight. We're gonna go back to Klamath Falls now.
So Russ, do you want to go
Oh,
ahead
sure,
and talk about?
thanks.
That was a great
This-
segue.
We've been kind of beating this one up a lot on how to deliver this. We know the schedule is a real problem. There's a lot of different ways we can do it. Marcy, you interrupt me and chime in if I start to blow it, but ideally, with winter coming, the way this, if schedule was not as much of a problem, we would move into design development, into construction documents, start thinking about getting a contractor on board, permitting at the local level and state level, maybe some material procurement, getting the site ready, starting construction when the weather let up and let us build without having to tent and heat concrete and wall around in the mud, and that always adds expense working through a winter like that. It is done though, but ideally, we would like to get all the way through soft cost work, design, permitting, contractor procurement, get some materials ordered, things like that, starting in, well, you all live in Lakeview, I'm guessing March, April, we get serious about starting to build. Is that fair?
Yeah.
Yeah. Which puts you starting then
May, June, being able to occupy.
May, June, move into phase 4.
2018. Oh, I'm sorry.
I'm sorry, let's see.
I was thinking total construction.
Oh, let's talk about, well, when can we get some people on the move,
Mhm.
which would be,
October.
yeah.
So
A year,
this time
from,
next
a
year.
year from now, move people out, move people into the new construction and reception. Again, that's ideal. Let's talk about not so ideal is we start looking for a contractor using some alternative methods, some CMGC, construction manager, general contractor, where we hire a contractor to help us finish the design, keep the budget under control. They can start planning their work way early, save us some time. We do the best we can to fast track the design. Maybe we package it up into small pieces. Hey, here's a foundation package and a site package. Let's go to work now while we work on everything from the slab up. There's a fast track methodology we can approach, but that puts us in building right through the worst time of the year. That's going to take money from your project. Some of that $4 million that we wanted to spend on clinic niceties, we're gonna have to spend on acceleration, overtime, propane to heat the site, snow removal, on and on and on.
Yeah, the other thing that, I mean, if we did go the faster track and had a contractor on board early on, what it also affords us is we can accelerate some of our design too. And again, there's a price for everything, but if they're on board, we could tackle phase 4, get those permit documents out, get them started on that while we continue developing the other work that's in the other phases. Those then would have, potentially, we could still tack that on to the original permit. It might end up being 2 other separate permits for those, but then we could have the contractor on site working while we're developing the documents for the other 2 phases. But again, that has us in the ground in the winter when it's frozen, and there can be issues with that. I mean, there's concrete curing in a very frozen environment. So there's drawbacks and there's pluses and minuses for both approaches.
If
Is
we, I'm
this
sorry.
slab floor?
We want it to be,
Okay.
yeah. If we grind it out through the winter, everything clicks into place, rather than get you in October, perhaps June into phase 4?
Yeah, June.
Maybe it'd save us through all, and then all that, struggling through the winter, could save us 3 or 4 months, maybe a little more. Again, depends on, I don't know what the forecast is this winter, sometimes it's really nice. If we get a good hard freeze and not a lot of moisture, and it's nice and sunny, but it's cold, that's good. If we get a really wet one and then it's, well, it froze and then it thaws and it freezes and it thaws and we're walking around in the mud, it just really kind of drags things out. I'm not thrilled about this type of construction and the finishes involved. Lots of drywall, lots of sensitive surfaces, dealing with that in those conditions and expecting them to perform the way we want. I worry about that. But like I said, it is done. There are ways to do it. Lots of tenting, lots of heating, a conscientious contractor can be done. So, but we would be, like Marcy said, starting to advertise, to get a contractor on board this month, and then we race into getting permittable documents for that first phase and getting started towards the end of the year, even finishing up in June for that first phase.
Now, we, in our last construction project, noticed a fairly steep pricing increase as time went on. Contractors are very difficult to come by.
There's a lot of building going on right there, and it is really hard to get contractors available and subs available without high prices associated with them. It's hard to get, it's great for our economy, it's bad for those that want to build, So there is definitely that consideration too.
We're plagued with that all over the state on our projects right now. We've had a project recently that I think we had a pre-bid walkthrough or even a bid, and we expected a dozen of a certain trade to show up, 2 showed up. And then their prices reflect that. They're playing the market. They know they can push the price envelope. They know we don't have a choice. The nice thing about a CMGC delivery format, we get a contractor on board early, get them as a member of the team, pushing for the common goal. When the sub bids come in, wow, these are high, what do we do? Okay, this contractor's, one of his jobs is to find something else in this project that perhaps we can redesign, lessen in size, change some construction techniques, do something to mitigate that. This went up, something else has to go down. That's really a lot easier to do when we have a contractor working with us as we design and bid, rather than completely design it, package it all up, invite people to bid on it, come into a room like this, open the envelopes and cross our fingers. Especially with renovations, I just don't want to do that. I'd rather know what those prices are going to be when time comes. So. But you're absolutely right. I've never seen it like this, and it's been almost 30 years for me. I haven't, we used to really pride ourselves on good engineers' estimates when it came time. And we're feeling really silly lately, that the market's doing weird things, so.
Russ, I have a question for you. On the expansion that you have for phase 5, if you did that, would that make the common reception area too distant? And therefore you would have to put in another reception? Unless-
That's a good question. Marcy can probably help us with that.
Marketing in wellness is always an option.
You're talking about this additional phase coming to the west here?
We may have, if we go to the aerial.
If you go to the aerial,
This
first
is
page,
coming right up
First
against
page,
your other wing right there.
It's right down there in
right
the,
hand corner.
can you expand that up?
We could
Okay.
explore that a little bit there.
there's also a picture right
It does appear to be, but you do have some.
Hold on, get it a little bigger.
Oh, wow.
There we go. That better?
So coming out this way, maybe perhaps one day, linking this all together, creating a separate entrance for separate hospital operations. And yeah, completely, you could do that, but it's becoming a big hospital, a bigger hospital. Is that done?
Yeah, I mean.
You know, you go to a great big hospital, there's reception. Do you know, even Skylake's Medical Center is not a terribly big hospital, but there's central reception and there's distance travel to get from here to there.
I know this is a clinic-based versus a hospital. I do a lot of work at Asante Road Regional Medical Center. And they still have their main north entrance. Everybody comes in that way, goes everywhere to the hospital. So I'm kind of like, if it works for a hospital, I think it would work. Plus, I also think people, when they come, they like to come to one place. They know they can go there and then be fed out to where they need to go versus, am I at the east, check-in, or am I at the north, it starts to get confusing. Now, depending on what discipline might move into that section of the clinic, that might be something that, as that happens and as you grow, you might want to reevaluate. But right now, I don't see why that central reception couldn't feed the entire clinic.
The reason I ask, one of the things we've talked about with our taking on the, what we're now calling our wellness center, the behavioral health services. And we've talked about how we want to create an opportunity for better integration. And so it might make sense to expand, excuse me, expand to the west on that side. Having two entrances might reduce the distance that people have to walk. And we do have long distances. This is, it's all on one floor. We don't have, like some of the bigger facilities that have elevators. So the distance, while it may be the same, it doesn't feel that when you're walking or going up an elevator.
Create that space. I mean, you have the room on the west to create additional parking based upon the kind of program elements you bring to those future expansions.
I wasn't thinking about parking, I was thinking about access for somebody.
It truly was dedicated, separate, specialty, that it made sense to have its own reception. We signed the site accordingly so people get there. I could see that making sense, but I keep thinking about what Marcy says, is if it's going to be just more of the same, that one core reception area just.
And if you are thinking behavioral health, I mean, that's a different patient population. That might warrant a separate entrance.
Well, when you look at your drawing on the page after that, where we look at how the corridor works, that corridor, right So the traffic pattern, for when a person comes from the common entrance, they take a jog to the right, and they go up to the end of phase two, they make a jog to the left and go up again, that would become a fairly actively trafficked area.
Yes.
And would that take away from the experience of people that are in phase two? The revised phase two, that it becomes now they're kind of in
A
the corridor.
thoroughfare, yeah, it's a thoroughfare through their
Right.
space.
Well, one of the, I mean, it's all shifts in design. Initially, we had the two existing corridors going straight through. But in order to accommodate the offices, exam rooms, offices, wanting more natural light, exterior windows, I shifted the program on that. And, you know, this is, at the time, the best answer we could come up with. Now, we can go back and, you know, there's give and take. We can certainly go back and explore the two thoroughfares, the existing, keeping the two hallways.
We did have
Yeah,
we had a
Originally, it was a straight shot.
We had a freeway going through there
Yeah.
originally, and there was some issues with
no, there weren't issues with that, but as we develop further, the request of, you know, private offices,
Right.
natural light, and just in terms of laying out the program, we can explore that in order to, and further, and see how can we keep that existing hallway as a straight shot, both of them, so we clear up a little bit of that central space there.
I mean, that's what I would suggest, especially if you know or anticipate when this might take place, is maybe you just make the one jog and then you just direct this over. And granted, maximizing daylighting, having offices, but we need to plan now for what can happen in the future. And if that's something that you foresee could happen in the next 5, 10 years, maybe 15, I think we should design appropriately for that now. And shift that over if you think that is going to be an issue with the jogging.
I mean, and honestly, a simple answer right now is literally shift that mast 10 feet to the right.
Yeah, you can just,
We just shift the mast, keep the hallway straight, and then, so,
Shift the whole building over?
yeah, just take that blob and shift it over so we make that hallway in line.
We can do a lot between schematic design
Yeah.
and design development to create that circulation.
Right.
No,
You bet.
I raised the issue because it has been a topic of discussion. It was not a topic that we talked about prior to us engaging it. And yes, you did change that location of the hallway based on a request to make the offices larger on the side, on the west side and getting natural light. But as the plan came back and we thought about this, number one, it butts up right next to where our rehab department is. And right now, we have a problem of people walking the long distance from the front of the hospital to get into rehab. And people, a lot of people are elderly, and that is difficult. We want to be as sensitive to our community as we can. And so as you have that expansion, we looked at how close that touches up to where our rehab department is. One of the questions that was raised is, you're touching, maybe that's where we have a back connection to our rehab department.
Is there enough room, Charlie, that you could put that to the left side of phase two?
You'd come pretty darn close to touching up to the existing rehab hospital. I mean, you're pretty darn close, even on the drawing that we have where it shows future expansion on the front page. It's essentially connected to the existing hospital.
Charlie, I think he was asking if it could go here. Right there, but isn't that where that panel is? I thought.
The panel is
The APS stuff?
south of that.
Oh, okay.
That's what I'm saying, take that to the south of phase two.
Well, then what you would do is the space between phase two and the hospital itself,
You're talking about right
You're
here.
up here.
that is space in there.
That makes the corridor shorter to get there.
But it would infill, you'd be butting up, I mean, the
We touch
hospital's
up to
right
the
here,
hospital.
correct, yeah.
Yeah.
Then you run into losing your natural light and the structural infill concept that Russ was talking about.
Yeah, that's what, yeah.
What we essentially do is create that area, take out, excuse me, take out the asphalt and create another internal garden in that environment. You create a nicer space so that you have a lot of natural space within the hospital campus if you do that expansion. Right now, it's just kind of a parking.
It sounds to me like you'd recommend starting development of your documents on for and reception, bringing a construction management on board at that time. And then not starting construction until spring.
That would allow us to have the contractor on board to help shop prices and help value engineer as we're going through this process, so that we can keep costs within budget. And the design development is a phase that's really critical too, and I hate to see that condensed or pushed too much because of questions like what Charlie just rose about, you know, how does this relate? Do we need to have a different entrance? Those are all things that as we work through the design development phase that we can start playing with legitimately. Is this something we need to think about now so that we can plan for the future when we actually build the new addition on?
Can't you do phase 1 and 3 in the winter though?
It's just while we're doing that, where do the providers and the patients go?
At one point in time, we talked about getting temporary buildings and putting them, but the problem is, no matter where we put them, we have, it's costly, we don't have parking, so you have to build all the other infrastructure components. And as Russ and I talked about it, it was not, we were throwing good money after bad. This is a more organized process. And that's why we didn't start off, as you suggested, is taking existing locations and remodeling.
I mean, there's definitely ways to, for a short time period, doubling up providers in an office if need be, so that we can tackle other things. But when you start shuffling so much and inconveniencing so much, it starts to really drag out the schedule of, okay, we'll move you over here for, you know, a month while we do this, and then we'll move. It becomes such a long, lengthy shuffle game that it makes more sense to add on, move everybody, and then gut and tackle.
Where do you propose that you put your contractors during construction as far as place so they don't lose our parking?
Well, staging and laydown, I haven't even given that much thought.
What,
Where
when
we're
they,
proposing the parking is a large open space.
What's
That,
The
Just up
north-
above here.
West of 4.
where were they when the hospital was?
They were to the south in the big open field.
Okay.
Across the drive.
But we will have long-term care out there, so that.
By the spring, by the time,
By
because
spring.
the project, long-term care project will be completed, call it April 1st, end of March, April.
We're building new cottages there, moving over to those, so that parking lot will be used.
that all would get very hashed out, especially with the CMGC on board during the design development phase.
Next step.
We'll sit down and talk with Russ and come up with a plan. This, we did provide, they did make the changes that were discussed at the request of the physicians. We have provided these changes to, like I did to you, to Juanita, to the doctors. So far, we have not had any other issues. So now we'll move forward. That makes sense.
I'm all for it.
It's impressive.
Yep. Thank you very much.
Thank you.
Thank you, Russ.
So we'll regroup when you're ready, Charlie? has been sometimes, it looks really complicated, and I'm really proud of what we managed to do with what we started. It was a very formidable task. I'm very proud of what Kelsey's done. I think she's really pulled her rabbit out of the hat. I was really worried. I thought we were losing Charlie and everybody else, but I really like where this is going, and it's been a lot of fun working with you. So far so good. We're hoping to keep doing things with you. So. And thanks for having us.
Thank
you.
Thank you. Drive safe.
Thanks.
All right, we're moving on. Let's see, Cheryl, let me Cheryl, we do. Not too long there.
All right, we're going on. Okay. Okay. Patient. Okay, I'll give it Nice to meet you. Huh? Okay, patient counts for August. Across the board, all through here, they were less than in July, and they were less than our prior year's average, except for swing beds, we had a couple more people in there. When we look down at ancillary services in the clinic, we see that the numbers are increased, both month over month and year over year. So they're big increases down here, which I guess I think is just a little bit weird, because usually lab and radiology follow the hospital and the ER to some extent. But there it is. All right, monthly revenue. These colors are really hard to see on the screen. So August monthly revenue was $2.7 million, which is this bar right here. Pretty much the highest month ever. 300,000 higher than our prior year average of 2.4 million. However, of note is 103,000 of it was from the behavioral health revenue that we recorded for the month. But still a good month. Our days in AR is right here. It went up a day from the prior month, so it's at 86 now. The average is 85. We've spent a lot of time talking about this, and we kind of determined that, we're just not identifying our problems soon enough. It takes us so long to figure it out and react to it. So we have hired a revenue cycle, audit advisory company to come in and help us figure this out and get it down to 60 where it belongs. We need to see those problems coming, and we need to solve them faster. It'll help us look at, if our staffing levels are appropriate, if we have all the tools that we need. There's forever and ever an endless number of emails that come to me every day to say, buy this piece of software and we'll make your days in the ER less and everything will be great. So we've kind of stayed away from all that stuff, but we also need to know, are we really using CPSI to the full extent that we could be? So the company we hired works very closely with CPSI and knows their software really well, because using the software well is key to getting our days in the ER down.
It's actually a wing of CPSI. What they found is so many of the hospitals that contract to provide the software were struggling like we with this kind of an issue. And so they developed a consulting line, and they had very good success. We'll see how good they are. But we've got to fix it.
Did you say when they were coming?
I have not scheduled a time for them to come yet. I'm still, we just signed the contract, and I really haven't talked to them about a date. I do know that I want to be, at least for the next 3 weeks, I need to be fully focused on the audit, because that paperwork is coming. The first step has already come, and we've completed it and sent it back. But the next 2 weeks, they're going to start gathering, they're going to want to look at lots of medical records and billing
records and AP records, and so we've got to pull it all, and we've got to answer questions, and the faster we do that, the more likely we will have a good outcome with the audit. So being that this is kind of a first-year audit again, you have to go back and there's a lot, some extra work with, they want to see lots of source documents like just organization documents and contracts and all kinds of stuff. So I need to spend my time on it.
Cheryl and I met with the team that will be coming in August when we were at the CPSI presentation for executives on what they're doing. So that's where we had a chance to meet and talk specifically about what it would mean, how it would work. So we just haven't scheduled a date.
But I should know more next month. Here's our collections for September and August and September, I mean. right here, and they're really close to $1.8 million. And it's not enough, given the revenue that we've been reporting. But that's reflected by our days in AR, so we know that's not enough, and if we can get our days in AR down, we're gonna get our cash collections up, so.
Are we receiving on a normal basis our behavioral health director?
Yes, I'm not sure if I can say that 2 months is normal, but we've learned a lot and figured out a lot, and some of the money comes through the county and some of it comes directly to us, and I do feel like there's still some more learning I have to do as far as any of the billing that's outside of Gobi or the county. That is still a little bit unclear to me, but yeah, we have collected quite a bit of money.
It's not a waiting game to get a license or anything like that?
No, oh no, I think we're contracted, I mean, yeah, no, we're good from that standpoint.
I can address that differently.
Okay,
We still have some issues that we're working through.
but we've got money.
We
We
have,
have received money.
I will
The
say
county
that
has not, has been very helpful, they send us.
what the county has done as of Tuesday, have now transferred all of the cash to the district. So we have that, but we still have the state and Gobi check that still been sent to the county, and they turn around and have to give it to us. So it isn't all finished.
No.
But it's getting, I mean, we're only into it 2 months.
But we just signed a Gobi contract, so I would think that next month that money should come to us. And I'm not sure, it'll probably take a little bit of a while to get the state money to come to us, but the county turns it right over to us, so it's a matter of a few more days. I don't feel like it's, yeah, bad. Okay. So, days cash on hand is right here, at 103. It is kind of an all-time low. However, days cash on hand would be 150 if you put back the $2 million that we have spent on long-term care so far and the $800,000 that we've already received from the county. So next month, I would assume this number's gonna jump up. I'm really expecting that we can fund the bond project before the end of October, and we do have the $1.3 million from the county. So this will look much better next month. Okay. Our profit and loss for the month, our revenue was $188,000 ahead of budget. Our salaries were $83,000 higher than budget. $62,000 of that was for behavioral health. And we had another $15,000 of this variance came from retro pay with some nursing issues that we had. Employee benefits was pretty close to where it needs to be, and materials and services, $234,000 over budget. So I looked through the budget pretty carefully, and temporary labor by itself in acute accounted for $22,000 of that 234. At lab accounted for $23,000 of temporary labor of that 234. PT was $20,000, the clinic was $40,000. So temporary labor is killing us right there. We had a big supply order for the lab, which was sort of an anomaly, but they came with a $27,000 overage on their budget just for lab supplies that will probably last a few years. Chemicals that they have to use. We spent $6,000 setting the mobile home up, so that was, it wasn't something we could capitalize, it was skirting and washer and dryer, things like that to get that set up and going. When the power went out and we had several rough issues, and we spent $16,000 between the HVAC and the phases and figuring out and fixing the problem where the generator shut down when the power was out because the movers were connected to the regular power instead of emergency power, so it shut down, didn't work. So that cost us quite a bit of money. And then we did do a lump sum out of IT for $10,000 for disaster recovery, which we budgeted and planned for, but, so IT's budget is a little bit behind or higher than budget, but it should smooth out as the year goes by. But that was also an anomalous expense. So it was kind of a rough month as far as these expenses are concerned, which ended in a net loss of $279,000, which was $125 more than we budgeted. So right now, the net gain for the loss for the month is $113, and for the year is $111.
Is there any chance to go back to the people that installed the louvers and the generator wrong to pay part of that cost?
My experience so far with Anderson Construction, which would have been ultimately responsible, we have some problems with our flooring. They have not been able to get the flooring people to come back since those were identified. There have been some outstanding issues that they, every now and again, I'll get a note from Anderson Construction manager who was here saying, I haven't forgotten you, I'll get after it. I wouldn't hold my breath. I think I'm glad we found out. It was a hard lesson to find out, but we fixed it. And I don't know, we might be able to get something back, but like getting any contractor to come, we're having a hard time for them to come when we pay them, let alone when they do a fixing or paying for the cost of something they didn't do right. Then we'd have to look to make sure that it was not their fault, it wasn't the architect's design. We might be able to get something. We can certainly look into it. One of the things I hope that you keep in mind when it comes to the actual versus budget, we did not put in any budget for, any dollars budgeted for behavioral health. And what we talked about, if you recall, in the month of July, was that because the dollar amounts does not exceed 10% of our annual budget, we don't have to submit an actual budget variance. We will, we're trying to get enough in, we have the budget that the county gave us and said this is what we think it will be. And we've been sort of using that. But as we get better at understanding what our costs are going to be and all that, we hope to have a budget for you to review. And what that will mean is we will always be under or over our budget unless we make that adjustment and present that to you. So we'll try to get that.
On paper, our rural health clinic isn't showing a profit at this point. But you explained that when it gets adjusted by Medicare, it should be break even.
Oh, yes. Oh, yes.
That should give us some more dollars.
And that's part of the process that Cheryl and her team are working on. And that will be part of the cost report. Because that's where that will be true. Another component of that, we've talked about how we submitted and we have been approved as a patient-centered primary care home. The increased dollars to us for the Medicaid recipients for that business, and we have about 900, is $50 per person per month. So that's a significant increase that will impact the revenue in our rural health clinic. And that we hope that payment will come very soon. It will be retrospective.
I think I brought this up last meeting, and maybe you said this too, my head is so stuffed up tonight, I'm really having kind of trouble hearing you guys, but I really would like to see, and maybe if somehow it cannot be reflected in our reports, but somewhere where our revenue and our expenses are separated out for behavioral health.
Yeah, so.
I would like.
I made a slide, so this is this month, and I'm gonna do that. So I have 2 things to tell you about that. So in August, I'll work on this some more. This is what we booked to the Behavioral Health Center this in August. In September, we spent a lot of money on supplies and building fixes and enhancements or whatever. We spent a lot of money on IT stuff, not computers, but whatnot. So a lot of money was spent in September and October. And I can't really put it to the, the Wellness Center department, but I am gonna keep track of it, and I will do this P&L so we can see exactly how the Wellness Center is doing. So the other thing that's really good though is I talked to our auditors at length and I said, I got this $1.3 million and I can't record it as revenue, went straight to fund balance, but I said, it's not right that I have to record all these things as expenses to the district, but I can't record that as revenue. And he said that there is something we can do, and it is very unusual, this whole situation is very unusual. But he's gonna look into it and tell me what we'll end up doing is on our P&L, we're gonna have some numbers, what he says is below the line. So after net gain, we're gonna have another line below it then we're gonna get to recognize some of that money as revenue so that the district's net won't be impacted by those extra expenses. So it might take me another month or 2 to get that all worked out, exactly how I do that, but I think that'll make a good difference. I think that's important. Yeah?
Another component of the salary costs that you saw in there, when the employees transferred over to us, we bought all of their benefits from the past, from the county. So that shows.
So the wages here of $62,000, that's not a normal monthly amount for their wages. almost 26,000 of that was accrued PTO. So next month that amount should only be like 25.
But you'll still see from going forward, it will look, the first year it's gonna be different. It's not gonna show just right.
So will that be a separate department? Or
It is a separate department, but the way that we do the accounting for all the other departments is most of the IT expense goes to the IT department and plant and maintenance goes to plant and maintenance. So I don't really want to do this one department differently because it confuses things, but I can keep track of it all and put it on here. So get those extra really direct expenses for you.
So you would treat that 1.3 million or whatever it is, kind of like a restricted reserve
Yes,
account.
yes, and then we'll just,
Draw down against it.
yes, exactly.
And Cheryl, what's incorporated in the contract services? Like what are?
That's mostly what we're paying CCS,
Oh, okay.
yeah.
So that'll go away.
That'll go away after,
Okay.
the end of October. I think that's just a payment for August, maybe, I'm not too sure where we're at with them. But CCS will be done by the end of October.
Actually, what ended up happening is we paid the July expenses also because the county transferred the money to us and said, well, we would have paid it and you wouldn't. When we passed all this money to you, as bills came in, so we still had bills from July that we were paying. And they said, well, we gave you the money, that's what we would have paid it out of. How do we treat that? So doesn't quite make it look perfect.
Yeah. Well,
But we're working through it.
appreciate the challenge.
Okay, so then going back a minute to the balance sheet, which really there's no significant changes. Our cash went down by 900, when you add all these cash accounts together, It went down by 900,000, but that's because we spent it on long-term care. We'll get that back. And our AR is up a bit, but really there's nothing that changed month to month. All right, and we already talked about the wellness center. I'm sure, I think we'll have a lot more to talk about next month. I think next month will be a lot of expenses. So does any questions on Lake Health financials? Okay. Where are we? No, we're not doing that here, we're doing it later on. Okay. Oh. Oh, before she goes. Good catch. I know, you like to just go on. I know, I did.
We do have an issue, and we would like to have, I don't know. Oh, this is not the right one. I think we did send out to you, no, maybe we didn't.
That's the one you gave us, isn't it, Jim?
Yes, this is, okay,
That's what I had. Yes.
so, where we're at with our bond process. And there has been an issue that was raised by our bond counsel. So Hawkins is our bond counsel, and Sherman is probably considered the best bond counsel for district work in the Northwest. And she's on the hunt with this. She helped us do she's done all of our work for us in the past. And last year when we did the $13 million bond issue, she helped us with this. What she was raised as a concern, I think we've talked a little bit about this, if not, we just make sure we're clear. The district cannot build or use bond funds to benefit another nonprofit organization. It can only benefit the district, because that benefits, that's tax dollars used for the benefit of this district. And so one of the concerns was that we were financing the Lakeview Gardens building, and that would benefit not the district, but Lakeview Gardens. What the state said was, we understand that the district still owns all the buildings, all of the equipment within it, and that Lakeview Gardens manages the care of the patients that are in those beds, but they don't own the beds, they don't own the building. So the state was just fine with it. Bond counsel said, you need to revise your lease agreement and your management agreement, because of all crazy things. When you transfer the license, when we transferred the license from Lake Health District to Lakeview Gardens, the form that the state uses is the transfer of ownership and management. And because the ownership component was listed there, that made bond counsel anxious. So what they're having the lease agreement say is it's transfer of management, taking out the ownership words. Almost finished with that. But at the same time, we also need to have, and this bond resolution, or resolution number 2016-5, could have been approved on the 18th board meeting or tonight. And what Gwen Griffin from talking to her, and she talked with you a little bit about that today, said it would be good if we approved that tonight. So if, that's why, I'm sorry it came, we just got it this afternoon. And we are trying to, we're moving this along because time is of the essence.
And what it's doing is giving, it's basically restating that who's going to sign and combine the hospital in regards to the lease and management. Because we don't want Charlie signing both of them on behalf of Lakeview Gardens. And if you get this now, they're going to want an opinion of council as to the changes on the lease, and this will facilitate that opinion of council. That's why we don't want to do it at the last minute.
I'll make a motion, we approve resolution number 2016-5.
Second.
Moved and seconded, those in favor?
Aye.
Aye, thank you. Motion passed.
Thank you.
Okay, now we're gonna do Lakeview Gardens. Lakeview Gardens had patient days of 698, which is up from last month. We are 322 days ahead of we were last year at this time. That's a lot of days. And now, they're popping over there. Yeah, we're happy. And here's our revenue year over year, also a huge increase. Where our revenue for the month was 198,000, well above prior year, well above last year's average. Awesome. Our P&L. All right, I decided I better start accruing taxes, so that's thrown in down here, so it's smoothing out the expenses a little bit, the way it should be. Here's some more contract labor, those CNAs, it really is hard on us when we don't have staff. But the good news is the net profit was $8,000 and $8,000. And so we are beating last year by some $65,000. It's hard to think of anything bad to say. And the balance sheet, month to month and year over year, our cash doesn't really go up because whatever we get in, we pay to the district. So you see the debt to the district keeps going down as they are generating their, keeping their AR in a good place. And their AR did go up, but they had a pretty high revenue month. So not bad. So questions on Lakeview Gardens? I guess Larry is going to give his report now, and then I'll do Goose Lake. Okay.
We wanted to give you an update on my training program. And next week, I'm going to Portland to take my assisted living administrator's course. And it's Monday through Friday. And at the end of that, on the end of the day Friday, I should get a certificate with my assisted living certification. So then that will be done. And then I'll spend the next 6 weeks with Charlie. And then my administrator training program will be completed, and I'll be able to sit for my state and national exams mid to end of November.
Very good.
Anyone have any questions?
Your assistant living up early.
All right.
Well, there's a lot of work that goes into getting everything ready. Because time, we now have, what, 5 months, 6 months?
About 6.
So it's hard to imagine that it's moving that far along.
Do we get to have like a christening party when he passes?
It's up to you.
Pop the cork.
Okay, so then Goose Lake, really quick, 'cause I know I'm taking a long time. Goose Lake's revenue was $54,000 for the month. You can see that that's a pretty good improvement over last year anyway, and certainly over the last several months that have been pretty tough for us there. So that's good. The P&L, the wages, unfortunately we had some wages incorrectly booked last month, so they got plunked into this month, so that looks kind of bad. We did lose $9,000. Where's my numbers? We are at a net for the year. I still don't have the month on here, but the net, we lost $9,000 for the month, but for the year, so now we're at kind of a break even there at $2,400. And the balance sheet, the good news is we are starting to collect money finally from Medicare. So that means that debt is going down. Cash is going up because we take all that excess cash and give it back to the district. Questions?
So are we running full staffing now?
Well, Dr. Gilbertson had surgery and she's not recovering well from it. So she had a month off and she is not really anywhere near back to being capacity. So that is rough. Tony is going great guns. I think maybe more than compensating for her not seeing as many patients And we're working on getting Dr. Lee and FMD Chalfin to work in California. So they're working on California licenses, which would also really help because we have the capacity.
Okay.
I sent you some information about the construction process, where we're at on that. We are about, at this time, about $160,000 difference from our $8.1 million. It isn't, probably the, and as you looked at that log of the kinds of changes, there's increases and decreases. Most of it has been increases, although we did get a decrease in fees from the architect, for example, because by not going with the greenhouse project, they didn't have to pay the outside consulting architect additional significant amount of money. So there are things that I thought were, I wish they had been found, but a perfect example of something that would not have been anticipated. When we have the room that we have for the tub room, there's a drain in that room for the tub. Makes sense. When Larry and Melinda went to the Veterans Administration facility, similar facility, what they found was sometimes people, and these are raised tubs. If you can imagine the Japanese tub where you sort of walk in, close the door, fill up with water, sit, and then drain the water, and then get out. People make a mistake and open the door, and they were flooding the tub room. So we had to add an extra drain, trying in case that were to happen. Those kind of things that sometimes you would not anticipate.
It flooded several times by the time we went. They were very disappointed they hadn't thought ahead of it.
So we felt it was prudent to do those kind of things. Another addition was something pointed out by Justin, is once the building is built and they have to go up on the roof to work on it, safety would call for hooks that they could hook their safety harness to. Those harnesses were not added, or those hooks rather, not the harness. So that was an addition. On the other hand, when we took out $30,000 for the capped wiring, it's not completely out because we're having Belton that does most of our low voltage wiring doing their component. Now, it's a little different, the pricing is different, about $10,000. So we're saving some, but it continues to be a balance.
So how did they take it out?
So when you look at the,
It's not being needed, is that what you're
no,
saying?
the cost was taken out because it's not done by that contractor.
Okay.
It's done by another vendor. So this is what is costs done by contract, right, construction.
Charlie, I know that there's a lot of material and it's very thorough there, but what would help me on that is if you could just have a little synopsis of this is above, below, we are on target today.
Okay. I can work on that.
I mean, because you go through that and analyze that, do that anyway, it just would help me if just at the bottom of that, there would be just a little short synopsis, okay, this is major changes on schedule. There's a lot of material to cover there.
There we go. And this is, we meet every week to review this. So there's a lot of things going on all the time. Now, we had hoped to have a time for you to come and see the construction site. Because they're constantly working on it, we want to try and schedule that for in the late afternoon. There's fewer people working, and we don't get in their way. We don't want to slow down their process. So I think Jen is working on getting a date for everyone to have a visit.
I think the consensus was the 14th, I just hadn't been able to get an email out on that yet, but I think everybody, all but one person, could make the time. But we could probably work on scheduling something for James.
So, and we are very happy to show anyone at any time the construction process, but remember, they're in construction. You have to wear the appropriate gear. You want to make sure you wear the appropriate shoes, or Detroit will ask you to sign a waiver, because
What's that appropriate?
closed-toed, non-heeled shoes.
You'll be okay.
Because of women.
If you wear high heels, Chuck, then I ask you to sign a waiver because of the possibility of twisting an ankle and maybe able to recover. So,
What time on the 14th, Jim?
and that really was designed to try and accommodate your interest in seeing it and limit the number of people that are working so you don't, and they want to make sure that they've got it cleaned up and safe.
It was 4, wasn't it? Yes,
Yes.
October 14th at 4.
I was truly surprised when we came out to do a tour. First, they had a gangplank that we could walk over, and as we came out, after having toured it, some of the workers had brought piles of rock to cover that where that gangplank was because of risk of us fall. Really, they're pretty careful. But I will try to get that for you, Joe. Any questions about the process?
Wanted to see siding, roofing. yeah.
Windows.
Is it, yes.
We also have pictures taken every week of the process. And so we have some of those on our website and others in long-term care. They're readily available. So it'll be fun to see the transition of that. This is pretty exciting. And of course, if anybody wants to come and sit in on the construction meetings on Thursday afternoon from 1 to 3, you're more than welcome. Any other questions?
I don't know. Your radiology purchase?
I sent out a note to you all about our CT choice. I brought the documents that you would like to. It was a pretty exhaustive process that the entire radiology department it got down to 2 vendors, General Electric and Siemens. Toshiba was the other potential vendor, but Toshiba has had some trouble with their delivering and their quality of late, so we elected not to choose from that vendor. We looked at Siemens and General Electric. Kyle went to visit the sites where they had current units, and they brought a lot of material. After exhaustive review, they recommended going with the Siemens. As I sent out to my email, I did sign an agreement to have them meet that in quarter, but needs to have your approval. As part of this deal, we looked at different financing options, and the rate, if you recall, the rate we're talking about for the bond issue is 2.75. It was 3 weeks ago. I don't know what it is right now. GE's financing arrangement was about 3.2, if I recall. And Siemens came in at 2.66. As I think I said one of the things that tipped the decision, we tried to look at 7 years for the 6 years for the payment of a piece of equipment and match the 6 years for the maintenance agreement, so purchase and maintenance. We added those together, and Siemens was cheap. But what was added as a benefit is that Siemens agreed to keep that maintenance agreement at the rate they're quoting for 10 years. So it's a fixed price for an additional 3 years. That's a huge savings, because this maintenance rate is actually $20,000 to $30,000 less than what we're paying currently for our existing unit. So, number one, I would recommend that you approve the purchase of Siemens unit. And then number two, I would ask that you would approve the executing the lease agreement, financing this piece of equipment through Siemens Financial.
And so moved that we approve resolution 2016-4 and the master lease purchase agreement.
I'll second.
Moved and seconded, those in favor?
Aye.
Aye.
Must add to that, the director had asked for an in-council agenda authority to do that. Jim has drafted one of those up.
And delivery?
We had asked that it be delivered before Thanksgiving and installed. One of the things that Siemens had requested is to make sure we get this approved by the board now as quickly as possible so that they could meet that deadline. There is still some, they're still juggling, but that's been our expectation before Thanksgiving. So that's pretty fast turnaround.
Yeah, you did mention you had a hiccup in your backup system.
So one of the issues that we found as going through this process, we will have a mobile unit while the construction is going on. It will be roughly 5-6 days, where it's, from when the old one's taken out, new one's put in and brought up to snuff. So we're going to have a temporary one on a truck. What we found is the requirements for that truck is that we have 125 amps. Well, our plug-in only has 100. And so we have to up the amperage, which means we have to, it'll cost us an additional $5,000 to have that electrically fixed. So that was an expense that we did not know about. And what was surprising is the whole time that we had the MRI unit, it worked just fine. The specifications call for 125 amps plus, but they didn't ask for it. So as far as we, I mean, it worked fine all that time, but we still have to make sure that it's right. And it would not be prudent for us not to have a CT scanner while this is done. Because we use it to vital for
Okay, thank you. Nursing reports.
Yes. Did y'all have a chance to look at this confusing policy? Do you have any questions?
Yeah.
What does it say?
I was just thinking maybe an example to walk us through.
An example?
Yeah.
So one of the reasons for this policy is so that it's easy for the nursing staff to understand what they should do when, and to also be able to document if they activate the chain of command. So a scenario might be where, the most likely scenario might be where the nurse might have some concerns about what's going on with the patient. And for whatever reason, they don't necessarily feel confident of the decisions the provider is making. So in that situation, they have the option of activating the chain of command, which would mean either they contact a nurse manager and the nurse manager contacts a medical director, or they contact the medical director directly. So in that scenario, it's essentially it's like getting a second opinion for the nurse. So the nurse can be reassured, or the physicians can discuss the plan of care in that situation. Does that help?
That makes sense.
That's the most common one. The other one is more to do with a staff member to staff member dispute, and that primarily then is just going up the chain of command through nursing. So,
It's like if one of your staff said in the surgery said, stop, I'm not happy, and the doctor said no, is that a situation like
that is less likely of an occurrence than a critical patient issue, either in OB or emergency or on the floor, where there's concern about the plan of care or the physician's attention to a particular problem. And in that situation, generally what they do is call me and I talk to the doctor or the medical, and then the medical director if we don't feel comfortable with what's going on. It's one of those things that happens usually outside of the patient's, no, the patient isn't necessarily aware that it's going on.
So this just kind of clarifies things, is that?
This clarifies things for the nursing staff, so they can document easily that they've activated the chain of command.
I make a motion that we approve policy number 9-01-0 for the chain of command activation.
Second that.
Moved and seconded, those in favor? Aye. Thank you.
And then I did have one other thing to present, although do you want me to go ahead with it? I was going to say if we can skip it I know this was a longer board meeting than usual, but one of the things that I think we brought this to you not too long ago, and talked about our program that we have started in the emergency room, where patients receive an automated phone call asking them
Yes.
if they have questions, if their condition has worsened, if there's any problems with them with transportation or making arrangements for a follow-up appointment. Everyone thinks I'm calling them because the initial part is my voice, but it is an automated system. And we have employed this company, Cypher Health, to do the phone calls. So they give us a monthly summary, and Charlie thought you might be interested in it. This is just the initial page of the summary. Whoops, sorry, I didn't send it the other way. I think primarily Jen, and I don't know if there's enough for everyone who's at the table, sorry. At any rate, the number of patients, if you look at the bottom under where it says grand total, the percent of patients reached is really a high percentage. National average is 50 to 60. So they're doing well at reaching the patients. And our percentage of patients requiring intervention is only 11%, so that's actually good. As far as our median time to intervene, so this is Abby, myself, and Carly, who are primarily responsible. If there's it's like a email message that kicks back to us and says a patient requires intervention, and so we kind of have our own little internal way of, Abby does it, if Abby's here, she does it first, and if she's not here, then it's Carly or I. So our median time is 63 hours, and our goal is under 48. So it's a little bit of a challenge because of the weekend too. But that's kind of where we're at as far as intervention. And then I guess just a few little stories that you might be interested in. Abby contacted one patient who had continued pain issues, and she intervened with the patient, got the patient to see a provider in the clinic. And at that point, the patient was ready to come back to the emergency room. So we got the patient in clinic, got the problem taken care of, and avoided an ER visit. So that was a good one. I dealt with a patient who had some difficulty during the time our MRI was down for a couple days, and was able to intervene with that patient and get the radiology staff contacted the patient directly and made sure that patient was seen as quickly as the MRI came back up. So that was helpful. And then another patient actually called me. I get calls periodically because people think I've been trying to call them. And this patient called and was expecting to be called and wanted to compliment the team and the doctor. So this was a patient who's been to our ER several times. So they've learned to anticipate the call and was waiting to pass on a compliment. So that was another nice little event that happened when I called that patient back. So just kind of an update on that system. I don't know if you guys hear about it a little bit out in the community. People are a little bit unsure about it yet. They haven't completely gotten used to it. People see me in the hall and go, "You've been trying to call me." So anyway, and I do have 2 new experienced nurse hires that started this week, so I'm excited to report that.
Good, excellent. All right. Personnel, we have Patricia Annie Johnson's son, Leslie.
Yes, I have a young woman who, after she met the 2 other Patricia Gainey recipients, 2 of the Patricia Gainey recipients in the last last month, attending Klamath Community College. They had told her about the program, the scholarship program with Patricia Gainey Fund, and this is a young woman that's moved to Lakeview, and she's been here just a little over a year now. She moved back to Lakeview, her mother's here, and she's going to school to get her LPN at Klamath Falls. She attended Klamath Falls last year, 2015. She's not currently employed with us, but she's looking at CNA positions, which several of them do when they're going through the LPN program. So she's applied. She has family here, extended family here. Plans on staying. She's got 2 young children that she would like to see go through the education process and go through the high school and be recipients of that wonderful program we have with our college tuition. And so she has currently applied. Her name's Devin Gaynor, and last year her GPA at Klamath was 3.8. She graduated with a 4.0 from high school, so she's very strong student and very committed to getting her LPN and then continuing on to her BSN. So I would like to recommend her to be a recipient of the Patricia Gainey Johnson Fund.
Help me again with the dollar amount.
$8,400 for the academic year.
She sounds like a strong applicant. I'd like to make a motion that we approve Devin Gainey that we award Devin Gainey the Patricia Gainey Johnson.
Second.
Moved and seconded, those in favor?
Aye.
Aye. Motion carries. Medical staff report, I guess Charlie, you might have anything to add.
Unfortunately, Dr. Hudson was tied up tonight, and so, well, he wasn't tied up, he was not available. I'm sorry, it means, so, and we don't have any set privileging issues.
All right, then we'll go on to the employee recognition.
Every month it's a great opportunity, and we have so many people doing so many great things. We've gone through several surveys of late. We received our DME for our durable medical equipment, medical supplies. That certification was approved, and that's a great thing for us. We had a couple of surveys in our radiology department, came back with no problems. Probably the one that really made a difference is we just finished our trauma survey as part of the emergency room. And the amount of work that it took to get ourselves organized, and we always are organized, but we had a lot of work to do. And Abby Finetti is a gal that really did such an excellent job. And the physicians that evaluated our results of our emergency room trials were very impressed. So I recommend Abby Finetti as our employee of the month.
They said we are the most beautiful hospital a small hospital in Oregon. They visited, so that was nice.
Who said that?
They did say that.
Did he?
There was a whole team here.
Yeah.
So, shall I get into my report?
Go right ahead.
First off, I'd like, when it comes to the work that we're doing with what we're now calling Lake District Wellness Center, changed the name. It's no longer Lake County Mental Health, although a lot of people still think of it like that. We've been able to hire several different people. We've added 3 new people so far, one of which is Trace Mosley. So, what did I say?
I don't know what you said. It was one.
Wanzer, excuse me, Trace. I can only
Yours
speak
just
English.
put a little punch to it. Wozna.
Wowzer.
So, we're very pleased to have her here, and she's actually going to be going, is it next week?
Yes.
Spend some time with Kimberly Lindsay, who has been our contractor overseeing this transition process, to hear how they're doing things and to really help spruce up what we're doing. As it comes to behavioral, since I'll talk a little bit about that, aside from hiring 3 additional people, both Trace and Kylie have started, but we have another licensed clinical social worker who will start in about a week and a half. That's really an exciting thing to add, to find some good people. We have many more, as you recall, from the study that was done by Gobi. A lot more work to do. Our Gobi contract has been signed and is in effect. They did put some stipulations in there. It is a 6-month agreement, but they anticipate if we do all the things that they're saying, that we would then have the normal longer term agreement. We met first September 31st deadline. We're working on our October, November, and they're addressing the items that were found in that Gobi survey that were deficient. So we're making a lot of progress. We have made a lot of progress with the building. It is, it's always disappointing to see when things haven't been done. We're taking care of it. So we're adding a heating and cooling system so that they will be able to stay comfortable during the winter and summer. The whole system is being replaced. We are adding, because the building was not really geared for soundproofing, we have soundproofing white noise equipment as well as putting insulation into the walls between office to office, so that you don't hear conversations one room to another, which unfortunately have been the case. We had to upgrade their electrical system. We couldn't accommodate what needed to be done. And then just all sorts of other general maintenance that needed to be accomplished. We anticipate, as part of this transfer, that fire marshal will be out. Fire marshal will be out to the North Lake office. I was up there on Monday in Christmas Valley, and by the way, met with North Lake Health District and secured from them approval for us to have our clinic there. As you know, districts are separated, and if we are going to have a second, if we're gonna have any service in somebody else's district, we have to get their approval, and we did get that. They also asked if we would relocate our offices into their building, which we'll look at as we go. We're engaged, the software system that the now Wellness Center uses is called Credit. It's a system used throughout the Gobi network that allows for billing as well as safe and secure patient information. In order to make sure that we get our staff and our IT informatics up and running on that, we're having special training for our staff to learn that. It's not something that we've had for long. We're also working with the state to make sure that we are doing all that the state requested. There were many things that were not being done properly. So we're taking them on one at a time. So I think that's, any questions about behavioral health that I could address, or any questions? A couple of things that I've been doing. I think I told you I went to Washington, D.C. to represent represent Oregon as part of it. Oregon and Washington group. We met, there were about 25 of us, and we met with many of our legislators. Mostly we met with Kurt Schrader's office, with Peter DeFazio's office, with Jeff Merkley's office. We didn't actually get to meet with representatives or senators, but their healthcare team. With Greg Walden, not only did we meet with his healthcare expert, but he spent the whole time with us. It's very nice when he asked me personally, how are things, his first comment was, how are things in that beautiful town of Lincoln? That's really nice to know that our congressman is versed with us. When we met with Wyden's office, we actually didn't get to meet with Wyden, but instead we met with the Senate Finance Community health experts. What we got to talk about, I think, is probably important for you to know. We talked about, and there were about 6 of us. We talked about the CMS waiver that we hope the state will get, because that it's a big deal. That's for continuing the CCO program. We talked about having site-neutral financing, so payments for surgery center off campus, same as what would be on campus. We talked about the 96-hour rule. This is the requirement that we have a condition of participation versus a condition of payment. As a critical access hospital, we have a condition of participation that says, on average, our length of stay cannot exceed 4 days, 96 hours. But CMS, in its brilliance, came up with a condition of payment that said the doctor has to document that the patient won't need to stay more than 96 hours. The doctor can't know when the patient comes in whether or not they're going to need 96 hours. Because if they can't document that, we have to ship the patient. Doesn't make a lot of sense. So we're again encouraging our legislators to change that CMS policy. We talked about the issues of direct supervision. We talked about, and that's where a physician, CMS is Medicare that oversees this, has we think, a very foolish rule that says a physician has to be present in our physical therapy department. They don't have to be present in our emergency room, but they have to be present whenever physical therapy is delivered. That doesn't make any sense. Asking them to change those rules. Another was to talk about telehealth and the importance of that, and then of course continuing the 340B program. So we have a pretty robust series of issues and comments that we might have. I think we were well heard. So that was, I believe it was well worth our time. I have for you, if any of you want to look at, I spoke last week at the state of, it's called the State of Reform was kind of fun that I was on the panel, not during the same time, but Bud Pierce, who's running as the Republican representative for governor, spoke the first part, and the past governor, Kitzhaber, he made his first presentation publicly since he stepped down at the new government. So I think our rural health voice was good. And that was, I heard many comments saying it was a good thing that people knew about Lincoln. So glad to tell you about that. When we deal with our Medicaid program, the CCO, as you know, we are at risk for the dollars for both the inpatient as well as the outpatient service. I think, did I send everyone the report on this? Not sure if I
No,
did.
I don't think so.
Well, we did get our report back. The CCO as a whole, Eastern Oregon CCO, did meet all of the required measures to get a bonus. Not all the CCOs did. And that was a significant impact for us. So as the system, that's about $9 million. And for us, the impact that it had on us, we are at risk, both the hospital component as well as the physician component. And combined, we received a check for $304,000. That's for the period from the last 3 months of 2000. The year is a little goofy. It is for the period January to March of 2015, and then for the period April 2015, March 2000, April 2015 through March 2016. That's that time period. So it's that $304,000 is in addition. So what that consists of, they had it withhold, money they held back in case they didn't meet the goal. So we got that back, and then we got about $133,000 for incentive dollars. So that's pretty good for us. On the physician portion, that really is using our electronic medical record to track metrics that are, for example, reducing our emergency room visits, or increasing the number of well-child visits, or immunizations. So there's quite a variety of different metrics. We will get about $12,000, but if you compare that to what they got in Burns, we are a third of what we should have got. And Burns population is about the same. So we have some work to do. And the truth is, we've been doing a lot of work. And we anticipate that our next period, the next award period, we will have made a significant difference. So, but I think $304,000 is a lot of money.
Where does that go in your budget?
We did not budget that, because that was an unknown, so that's extra cash. That is for the Medicaid portion of this business. Other than that, it's been kind of slow.
Yeah.
Any questions?
Well, yeah. I got a little bit of housekeeping. I want to welcome Trace on board.
Thank you, it's a pleasure to be here.
Next month, the meeting on the Thursday would be the 3rd. Is that too soon? Or it's December, which there's a lot of stuff later in December we have to
November.
November, I'm sorry. November. I'm a month ahead.
I'm scared for
Yeah, you've got the same problem.
I think we're okay.
You're okay with the 3rd?
Yeah. Yes, we are.
Is that okay with the board members? Okay, we'll leave it as is. Do we have executive session items tonight? We do. In that case we will take a 10-minute recess and return with the board, Charlie, Dave, anybody else.